We're very privileged today to have William Stevenson as our guest visiting professor. I'll tell you a little bit more about the rest of our panelists. Just to tell you about the upcoming few months. In January, Dr. DeMaria from UCSD, current editor of Journal American College of Cardiology. In February, Andrew Epstein from University of Pennsylvania. In March, Joe Lascalzo from Brigham and Women's Hospital. In April, Ken Ellenbogen from the VA Virginia Commonwealth. In May, we have David Holmes from Mayo Clinic, and in June, Chris O'Connor from Duke. If you do have questions throughout the course of the discussion, please, you can send them by email to Heart Currents. It's one word, heartcurrents@mountsinai.org. Our next program, as I said, is January 13th, and that will be Dr. DeMaria. The archives for today's discussion will be available later this week on heart-talks.org. heart-talks.org. Just to plug some other live webcast programs that are coming from Mount Sinai. Tomorrow morning at 8 a.m. on cclivecases.org. cclivecases.org. Dr. Sharma does live cases from the cath lab, very challenging cases with really interesting in-depth discussions of technique and of the evidence-based literature based upon the patient's specific diagnosis and management. And later on Wednesday at 8 a.m. the following day, so Tuesday is from the cath lab in the coronary cases. On Wednesday is Dr. Krishanan's peripheral intervention webcast, Wednesday 8 a.m., a week earlier than usual, and that's on peripheраlinterventions.org. I just want to express Dr. Fuster's best wishes for a happy, healthy New Year and best of holiday wishes. He finished his course yesterday where he had around 2,000 people. The largest course outside of the American College of Cardiology's annual course here in New York City, and he was called away. In his stead, we have very able moderator, Dr. Vivek Reddy, who's professor of medicine, director of cardiac arrhythmia service. The panelists will include our visiting professor. Dr. Reddy will present more formally in a few minutes. Dr. Dukapati is co-director of Electrophysiology, director of Electrophysiology Fellowship Program here at Sinai. Dr. Kinney, who's professor of medicine, director of Cardiac Catheterization Laboratory, director of Interventional Cardiology Fellowship Program. Also, Dr. Mark Miller, assistant professor of medicine, Cardiac Arrhythmia Service here at Sinai, and Dr. Sean Pinney, director of Advanced Heart Failure and Cardiac Transplant Program. They're also going to be joined on the podium by Dr. Sandeep Gangridi, who is going to give you a brief discussion of today's topic, which is sudden death in coronary artery disease. Are defibrillators enough?
Thank you, Dr. Goldman. Ladies and gentlemen, distinguished guests, I just want to thank you for allowing me the opportunity to talk to you today. And before we begin, I just want to acknowledge the support of my mentor, Dr. Vivek Reddy, for all of his help in both preparing this manuscript and for his guidance over the years. Our topic today is sudden cardiac death in coronary artery disease. Are defibrillators enough? And I want to start this off by saying I think the answer here is no, particularly given that sudden cardiac death accounts for about 300,000 to 400,000 deaths annually in the United States, or about 5.6% of annual mortality. Now, the majority of deaths in patients with coronary artery disease are due to acute ischemia resulting in either polymorphic VT or ventricular fibrillation, which occurs with an incidence of about 3 to 8%. And in contrast, sustained monomorphic VT is more often due to scar-related re-entry that occurs in the setting of healed myocardial infarction. So typically, these fatal arrhythmias follow a cascade where acute ischemia triggers VF, or polymorphic VT in patients with prior scar, or monomorphic VT in patients with a prior scar. And this VT they then degenerate into VF followed by asystole. Now, the incidence of VT up to 6 weeks following myocardial infarction is estimated to be about 1%, and this has actually been dramatically reduced over the years due to advances in management of myocardial infarction, including earlier reperfusion and optimal medical therapy. However, the mortality among patients who develop early VT remains as high as 35%, and the incidence of VT up to 2 years post-infarct is estimated to be at least 23%. So how do we treat these patients? Well, typically we use a strategy combining antiarrhythmic drug therapy, ICD therapy, and catheter ablation. Now, unfortunately, we know that antiarrhythmic drugs don't work very well. This data comes to us from the OPTIC trial, which evaluated patients with ICD implantation at 21 days of inducible or spontaneous VT and randomized them to either amiodarone plus a beta blocker, sotalol alone, or beta blocker alone. And although there were less shocks in the amiodarone plus beta blocker group, 10.3% of patients still received shocks, and up to 18% of the patients discontinued amiodarone due to their adverse effects. By comparison, ICD therapy has a proven mortality benefit when used for both primary and secondary prevention outside of the first 40 days post-MI, and this data comes to us from the Dynamite trial. Now, there have been several trials, the MUST trial, MATE-2, and SCUD-HEF trials, which have demonstrated a roughly 20 to 30% mortality benefit for primary prevention ICD therapy in patients with coronary artery disease and reduced left ventricular ejection fraction. And similar reductions in mortality, around 30%, were seen in secondary prevention trials, such as the ABBOTT trial. However, these patients continue to receive ICD shocks. In primary prevention trials like MATE-2, 24% of patients received a shock or ATP at 21 months, and in SCUD-HEF, the number was again 22% at 45 months. And after the first shock, recurrence still occurs in these patients, so around 53.3% of patients have a recurrent shock. And in secondary prevention trials, these numbers are still higher. So in VTAC, it was 71% at 2 years. In SMASH-VT, it was 31% at 2 years. In OPTIC, it was 38.5% at 1 year. So these ICD shocks not only reduce the quality of life by inducing things like post-traumatic stress disorder, but they may also contribute to mortality. So a study by Sweeney and colleagues analyzed 4 trials, including the Pain-Free 1, 2, Empiric, and Prepare trials, and found that each shock resulted in almost a 20% increase in mortality. So I think what we've realized now is that these shocks should be treated as an alarm sign to reevaluate patients for acute ischemia or acute decompensation of heart failure, and further shocks should be prevented either by antiarrhythmic drug therapy, programming as demonstrated in the MATE-RIT trial, and catheter ablation. And catheter ablation has been shown to be effective in reducing ICD shocks in several trials, particularly the SMASH-VT trial by Dr. Reddy and colleagues, which randomized 128 patients with a history of MI who underwent ICD implantation for spontaneous VT or VF to either ICD implantation alone or ICD plus substrate-based catheter ablation. And a follow-up demonstrated that 33% of patients received ICD therapies in the ICD alone group, compared with 12% of patients who received the ICD plus ablation. Similar results were reported by the VTAC trial, which demonstrated a 47% freedom from VT recurrence in 2 years in patients in the ablation group, compared with 29% in the control. And again, the Thermocole VT observational study by Dr. Stevenson, which demonstrated freedom from VT at 6 months in 53% of patients. So although catheter ablation has been shown to be effective, unfortunately it's typically used as a therapy of last resort. And this was confirmed by a study by Marchlinsky and his colleagues, which demonstrated that late referrals, in this case defined as referrals where 2 episodes of VT have been separated by at least 1 month, have been shown to have worse 1-year VT-free survival outcomes. So with that, I'll ask Dr. Ray to come up and introduce our distinguished guest, Dr. Stevenson. And the first question I'll leave to the panel is, so should we be referring these patients earlier for catheter ablation? Thank you. Dr. Ray.
Thank you very much, Sandeep. So what I'd like to first do is to introduce our guest of honor. It's my pleasure to introduce Bill Stevenson, who's been an icon in our field for certainly as long as I've been an EP, but I would just want to go through his CV really quickly. It's way too long to go through completely, but I'll just go through a few points. Bill Stevenson, he finished his medical school and medical degree. He obtained at Tulane Medical School in 1979. He then performed his internship, residency in internal medicine, cardiology fellowship, and he actually served as a chief resident in medicine at UCLA Medical Center, which he completed in 1984. He then spent a year in the Netherlands at the University of Limburg in Maastricht for 1 year. And then he came back to the United States and started as faculty at the UCLA School of Medicine. And he was there, it looks like, for about a decade. And then he moved to Boston to Brigham and Women's Hospital, where he stayed basically since then for the next, I guess, two decades or so. Bill served as director of the Cardiac Arrhythmia Service, the Clinical Cardiac Electrophysiology Lab, and of the Cardiology EP training program at Brigham at various times. And he currently serves as the director of the Cardiac Arrhythmia Program at Brigham and Women's Hospital. He has a number of national and international positions in various committees. I'm not going to go through all of those, though I just want to highlight that he's been one of the co-directors of the Advanced Ablation course, which is run by the Heart Rhythm Society, the major electrophysiology society, for almost a decade. I think he had to recuse himself recently because of his position in the editorial board of circulation. And I think that's one of his more important positions. He served on the editorial board and as the associate editor of Circulation since 2004, since Circulation moved to Harvard Medical School. He's also the editor-in-chief of Circulation Arrhythmia, which he co-founded, or I guess he founded in 2008, and has served as the editor-in-chief of that journal. He's also, I sort of skipped over this, I guess, but he is currently professor of medicine at Harvard Medical School. I didn't really go through his medical appointments, but he's currently a professor of medicine at Harvard Medical School. And he has a number of different honors, and I'll just point out one of them. Last year in 2012, he received the Moravsky Award for Excellence in Clinical Cardiology and Electrophysiology. This is one of the major awards given by Heart Rhythm Society. And it was given to him for his teaching and his excellence in electrophysiology. In terms of what he's done in electrophysiology, he has numerous papers. It's over 150, 160 papers. I think beyond the papers, he's sort of redefined or has defined our understanding of how to map ventricular tachycardia, how to think about ventricular tachycardia, and has given us a framework of how to think about it instead of simply just moving catheters around. I think that he truly is one of the pioneers in our field. And with that, I'd like to ask Bill to come up here for 1 second. I'd like to give you this award. This is the Anandhi Sharma Visiting Professor Award. It says, expressing appreciation to Bill Stevenson. But to give that to you, Bill.
Thank you
very much. And we also have a honorarium. If your circulation, conflict of interest precludes you from accepting that, I will be happy to take it.
Thank you very much.
So with that, I'd like to call everyone on the panel to please come up here. Bill Stevenson, Sandeep, I think Srini is coming up. I don't remember who else is on the panel. Let's see here. That's right. Sean Pinney, Anu, Kenny, and Mark Miller. Okay. There are a lot of potential subjects to go through, so I want to start off. With defibrillators and what they do and what they don't do. We know from multiple studies, from MADE-IT, MUST, SCUD-HEFT, CASH, SIDS, etc., that defibrillators save lives. We know that defibrillators are useful in patients who are at high risk for sudden death. Initially, the definition of high risk was based on individuals who sustained a ventricular arrhythmia, and then more recently we understood that anyone with a reduced ejection fraction is at high risk for sudden death. We know that pharmacology in general has not been successful, at least beyond beta blockers and ACE inhibitors and aldosterone antagonists, but antiarrhythmic agents themselves have not been particularly useful, but defibrillators have been. Having said that, as Sandeep pointed out in his initial presentation, defibrillators have issues, and we know from MATED 2, MATED 3, I'm sorry, we know from MATED 2, we know from SCUD-HEF that patients who sustain defibrillator shocks have a higher subsequent mortality than patients who don't. Now, having said that, there are two recent pieces of evidence which are, I think, somewhat contradictory, and I want to bring these up, and I'd like to start the panel discussing these. The first is actually not a randomized trial. It's a very large registry. It was a Latitude Registry. And this was published in Bill's journal, I think earlier this year. So the Latitude system, it's a remote monitoring system. The patients who have defibrillators are monitored remotely. This particular system allows a lot of the patients to be followed. And in some sense, it actually captures real-world experience with the defibrillator, since everybody who gets a defibrillator is on the monitoring system. So there were almost 4,000 patients who were followed through the Latitude system. And these investigators, they looked at patients who had an event and looked at the subsequent mortality. And what they found was interesting. First, patients who had a first shock from monomorphic VT or ventricular fibrillation had a higher subsequent mortality. This is interesting. It's interesting because it was in a large number of patients in real-world experience, but not terribly surprising since we already knew this from SCUD-HEF and MATED. But the mortality, just to give you numbers, if you have a VT event, your subsequent mortality is 1.6, your hazard ratio, so 60% higher than if you don't have an ICD shock. With VF, it was 2.0. Now, it was also interesting that if you had a shock for atrial fibrillation or atrial flutter, the subsequent mortality is 1.6. So even if you have a shock for an inappropriate shock, albeit for atrial fibrillation, atrial flutter, the subsequent mortality was higher. But what was interesting, if you had a shock for sinus tachycardia or due to lead noise, then the subsequent mortality was no higher than if you had no shock. Okay, so the question that these investigators really were trying to address is, are shocks bad for you? You know, if you have a shock if you have an inappropriate shock and your mortality increases, and that suggests that a shock is bad for you. But interestingly, only one type of inappropriate shock increased mortality, which is atrial fibrillation, atrial flutter. An inappropriate shock because of lead noise or because a patient was running too fast and the device was programmed as such didn't increase mortality. And that suggested that maybe shocks by themselves are not bad for you, but patients who present with an ICD shock, either appropriate for VT or VF or inappropriate but for a rhythm that may be a marker of heart disease, such as atrial fibrillation, suggests subsequent mortality. Okay, so that's one piece of evidence that suggests that shocks themselves are not bad, but they highlight underlying disease. Then you have another piece of evidence, which is MATED RIT. MATED RIT was published last year. You know, it's one of these trials that really nobody with electrophysiologists really should care about, but it turns out everybody will care about it. MATED RIT was the idea was to look at different ways of programming defibrillators to see if you program it differently, you can prevent subsequent inappropriate therapies. And so there were three ways of programming. One was sort of the default way of programming, and we don't really even need to get into the details. The second was called high-rate therapy, meaning the device would only deliver therapy for very fast rhythms, okay, over 220 beats per minute. And then the third way of delivering therapy was a delayed therapy. So basically, no therapy would be delivered for at least a minute. The patient has to stay in sustained tachycardia for at least a minute before any therapy is delivered. And as you'd expect, these second two ways of delivering therapy had fewer inappropriate shocks, and that's not a big surprise. It was a little bit of a surprise that you didn't have more syncope in these other ways. So delaying therapy for a minute didn't really increase the amount of syncope. What was most interesting is that these second approaches, the delayed therapy or the very high rate therapy, actually showed decreased mortality compared to our standard approach. So we have these two different pieces of data, the Latitude data suggesting that shocks by themselves are not bad, the MATED RIT data suggesting no, shocks may actually be bad for you. What do you think, Bill? I know it's a complicated question. What do you think about that?
Well, with both of these issues, I think I'll bet it's like a lot of things. I'll bet there's some truth to both
of those mechanisms. So it makes a lot of sense that when somebody has a spontaneous arrhythmia which is sensed by their defibrillator, that often the occurrence of that arrhythmia is a marker of some deterioration in their cardiac function. So even if it's an atrial arrhythmia that results in an inappropriate shock, we all know that atrial fibrillation is associated with an increased risk of mortality and heart failure. If it was ventricular tachycardia that was appropriately treated by the device, the fact that they had an episode of VT, as Dr. Reddy mentioned, we already know that that's a marker for increased risk of heart failure hospitalizations and increased mortality. So I have no trouble accepting that that's one possible contributing factor. On the other side, are shocks bad? Well, you can certainly show that applying a high voltage shock from a lead in the myocardium punches holes in the cardiac myocyte membranes and kills some myocytes that are in sufficient proximity to the lead that they're subject to a high enough voltage gradient. And it would make sense that you get a big sympathetic surge in response to a shock, and we know that increases in sympathetic tone are bad. And as a consequence of any injury, it's likely that there's some inflammatory response. And we know that inflammatory responses in the cardiovascular system are bad. So I wouldn't be surprised if there's some truth to both points of mechanistic suggestions for how a shock may translate to a worse outcome.
Sean, let me just have you follow up on that. You see a lot of patients, you take care of a lot of patients who have defibrillators and have heart failure, and some of them have shocks. And what do you consider, or what do you think is the right thing to do in terms of at least medically managing these patients initially when they have these, when they present with shocks?
Well, I think, we treat an ICD shock as a sign of worsening prognosis,
right,
which is an opportunity for us to revisit their neurohormonal blockade. I think all opportunities present themselves to revisit expanding neurohormonal blockade, whether it be an admission to a hospitalization or an ICD shock or a sudden change in symptoms. You want to make sure that patients are appropriately receiving the therapies that have been shown to improve survival. So I would use it as a wake-up call to make sure that they are appropriately receiving ACE inhibitors, beta blockers, aldosterone antagonists at the highest tolerable doses, and also make sure that they're plugged into a disease management program. Obviously, the presence of a shock identifies them as being at higher risk over the next year, so you want to make sure that they're plugged into that disease management program or a center that can offer advanced therapies for heart failure just in case they do worsen.
Okay. In your introduction, Sandeep, you brought up ventricular tachycardia, and you brought up in the context of a couple of clinical trials. What I thought we'd do is, let me just go over the clinical trials, SMASH-VT and VTAC, which are the major randomized trials that have been performed. But then beyond that, there are a number of registries and large other studies that are out there, and I'd like to have people comment on them. So SMASH-VT was a trial that we did. It was not a very large trial, only 120 patients. But the idea was to say, well, if you take patients who are getting an ICD and have a high risk for having shocks, that is, patients who've already had one ventricular arrhythmic event and therefore are about to get a defibrillator, what if you also do catheter ablation at the same time? And what SMASH-VT showed was that you can decrease the subsequent risk of ICD shocks, and it was performed quite safely. There were no major complications in the ablation group, and there were significantly fewer events in the ablation group. VTAC was a similar trial design carried out in Germany. More centers, again, just over 100 patients, and very similar outcome. VTAC also looked at cardiovascular hospitalization and showed a significant decrease in cardiovascular hospitalizations. And there was actually a more recent on-treatment analysis of VTAC that was published, again showing that those patients that actually underwent ablation fared much better than those that didn't with respect to subsequent ICD shocks. Now, having said that, that's really, I wouldn't say that's the way most people practice. That is, when one gets a defibrillator, we don't immediately do catheter ablation. And I'm just wondering, Bill, if you want to comment on where do you think SMASH and VTAC, where should they fit in our clinical practice? That is, the concept of adjunctive ablation at the time of defibrillator implantation.
Yeah, we certainly would like to prevent shocks prospectively in people that are receiving defibrillators. And as was mentioned previously, antiarrhythmic drugs have been disappointing in that regard. But it's been a little bit of a high hurdle to accept ablation therapy for that purpose, for somebody who's not had recurrences. And I think that the issue, there are two major concerns. One is the risk of complications from ablation, which although was essentially zero in the SMASH trial for major complications, when you start translating that perhaps to a broader group of electrophysiologists who may not have quite the level of expertise as the trial centers, even a couple % incidence of a significant complication would be enough to be of concern when you're applying that therapy to a group of patients who haven't yet had repeated recurrences. And then the second is the number of centers that are facile with Vt ablation and who have it on their at the top of their procedures in the EP lab are relatively few. So I think it's those reasons combined with the fact that although it clearly reduced VT episodes, reduced defibrillator therapies, neither of the trials was sufficiently powered to show a mortality benefit, which would really be, I think, required to drive that sort of therapy.
So, Srini, would you like to comment on where do you see the role of VT ablation right now? Meaning, in most people's practice, let's say at least at centers that do a good amount of VT ablation, where do you see the role?
Well, I think that VT ablation is probably underutilized. I think the easiest thing to do when a patient has VT is just start an antiarrhythmic drug, presuming that it'll hopefully go away and you save the patient from a complicated procedure. But in reality, in my opinion, just starting an antiarrhythmic, you're just buying time. I think they're going to come back at some point in the future. They may come back in a sicker state. And I really favor early intervention. Now, at what point do we intervene? Should we be taking primary prevention patients and doing a program stimulation to see if they're inducible and then doing VT ablation in those patients? I don't think we have the answer to that, but I think that's something that as an electrophysiologist, I think we should look at, and I think we can really change the arrhythmic course of patients by early intervention. And SMASH VT had a trend towards mortality benefit in the secondary prevention patients who received an ablation as adjunctive therapy, but it wasn't powered enough to detect that. So I think, at least my preference for selecting patients is early intervention. Even one shot, I start looking at what type of arrhythmia is it. Is it a monomorphic ventricular tachycardia? If it is, then you look at the substrate. If it's a dilated cardiomyopathy, I'm less likely to rush those patients in. Whereas if it's a monomorphic ventricular tachycardia in a coronary artery disease patients, I think those patients do better with a substrate modification-based approach or an ablation in general. And I think in those patients, we should be intervening earlier.
So before I get off this topic completely, let me just ask Sandeep. So you've heard what people said, you've read the literature, and what is your thought? What trial needs to get done next, or trials need to be done in order for us to better understand whether or not this is where we should be using VT ablation?
I think it's a great question. I mean, I think there's one study in particular that has already been done looking at early ablation versus later ablation that was retrospective and found that people who were referred for catheter ablation early, this was by Frankel and colleagues, found that they had better outcomes when people underwent an early catheter ablation compared to late. I know there are several trials now, the Aspire trial and I believe the Vanish trial, that are going to be looking at earlier referrals for catheter ablation, and hopefully will give us some of those answers. And maybe Dr. Stevenson wants to comment. I think we're working a little on the Vanish trial.
Bill, what are your thoughts on these trials?
No, we definitely need some randomized trial data that gets at the mortality issue, or maybe mortality is tough, but this is a pretty sick group of patients. So they actually, in some of the observational multi-center trials in this group, their mean EFs are in the order of 25 to 30%, and the 1 year mortality has been as high as 18% in some of these trials. So there is a chance that you would have a meaningful impact on mortality. So a randomized trial of early ablation versus later ablation. The Vanish trial is randomizing people who have already failed antiarrhythmic drug therapy, typically low-dose amiodarone, randomizing them to higher-dose amiodarone versus another drug versus catheter ablation. And they will not be sufficiently powered to have mortality either, unfortunately, I don't think.
So let me ask you about the data that we do have beyond the sort of early intervention trials. There's a fair amount of data out there in terms of ablation of patients who have ICDs, who then present with multiple ICD shocks, appropriate shocks. And do you want to comment on the Thermocole study? The Thermocole study was probably the very first really big Vt ablation trial in the modern era, which you led. Can you make some comments about that?
Yeah, so in the Thermocole trial, it was a multi-center trial, and it enrolled 231 patients who had prior myocardial infarction and recurrent VT related to the prior infarction. Mean ejection fraction in the range of about 25%. And the observation there was that at 6 months, about half of the patients had had a recurrent episode of VT. So from that, it suggests that ablation was certainly not going to replace a defibrillator. However, about 70% of patients had a substantial, what was felt to be a clinically important reduction in the frequency of their VT episodes. So there were many patients who went from very frequent episodes of VT down to one episode in that 6 months. The other thing that the trial pointed out was the complication rate. And there was a 3% mortality. And most of that mortality was due to uncontrollable VT when the procedure failed. So you can imagine someone with poor ventricular function, recurrent VT, is sent for consideration of an ablation. If the ablation doesn't get their VT under control, things probably aren't going to end well. And that was the major source of complications. Interestingly, the risk of thromboembolic complications of stroke was extremely low. In fact, there were none in that trial, and the major other risks are of vascular sorts of access complications, which are by and large manageable.
And let me ask you, heart failure, as you pointed out, was one of the biggest complications. One of the options that we have now are we have better devices for supporting blood pressure during these procedures. And so, Mark, you're the lead author on a paper that we published a couple years ago on using ventricular assist devices during Vt ablation. Do you want to give us your thoughts on, I mean, certainly it can be done in lots of patients. The question is, when is it appropriate? What kind of patients do these devices, or should assist devices be used, and what are the benefits that we may realize?
So I think if you look at, just to echo the earlier statements, if you look at VT ablation, it's 3 categories of patients. The prophylactic catheter ablation, obviously it would not be appropriate for that. If you look at it from the most extreme example, the patients who come in decompensated with multiple ICD shocks and heart failure, I think that's an appropriate patient population, because even if you want to just do mapping and ablation and VT, it is useful to have some degree of support during an 8-hour procedure under general anesthesia. The other patient population, the middle patient population, the stable patient that comes as an outpatient after 1 or 2 ICD shocks or ICD therapies, those patients generally do well without any support of any kind, and you can just do a substrate map, which is probably the same safety and complication rate as just doing a straight AF ablation. The overall complication rate is quite low in those patients. So for the sick patients, and it's unfortunate because most of the patients that we see, it's almost like a skewed perception. They say, well, the VT ablation is a complex procedure. Well, that's because usually they're being referred quite late and they're already hospitalized and quite sick. Really, the patient population should be moved earlier so they don't reach that point. But assuming they do reach that point, it's very useful. And as Dr. Stevenson said, the issue of patients who are hemodynamically unstable. So there's a couple of, patient population that are unstable cannot be mapped during VT. There are times that it's actually useful to map during VT. Obviously, at that time, PLVAD support is useful. But then there's the whole question of how much do you have to do during a VT ablation. So I know there's a recent publication showing that, at least in the non-ischemic patient population, that if you're not inducible at the end of the procedure in any form or fashion, it's better outcomes. Now, how far do you have to take that? I mean, you can run a VT ablation for 12 hours until you've targeted and ablated every inducible VT. So in those situations, depending on how far you want to go and how long the procedure is and how sick the patient is, in those particular situations, I think PLVAD support is useful. There's no doubt that, and I think most people, at least anecdotally, would agree with this, that the patient after an 8 or 9 hour VT ablation who's, let's say, been hospitalized with acute decompensated heart failure prior to the procedure is healthier coming out of the EP lab after having 7 or 8 hours of PLVAD support than the patient who did not. Now, there's a cost benefit to that, and there's obviously procedural characteristics which have to be taken into consideration. But I think if it were free, we would probably do it in every patient, but it's not.
It's not free. Let's talk about, obviously VT ablation is not successful in everyone. Can we talk about why it fails? So there's a recent publication, this was in JACC earlier this year, late last year. Earlier this year. And this is from the Michigan group, and they looked at a number of different patients that underwent VT ablation, a total of 100 patients. They had a number of VTs that were ablated, and they looked at those patients that came back for repeat procedures. And what they see is that the patients that come back with second procedures, they felt had VTs that were different than the initial target VTs. So the question I have is this issue of changing substrate. Is the substrate changing? How much success can we actually hope for during a VT ablation procedure? Bill, do you want to comment on that?
So the history of electrophysiology has been that anytime you implement any therapy that changes the electrical properties of the substrate you're dealing with, there's the potential for some things getting better and some things getting worse. Yeah. And unfortunately, I think ablation is not different in that regard. So when somebody recurs after an ablation, one possibility is that the lesion that was created at the time was not durable. It healed, and the extent of the area of damage that was anticipated was less than after the lesion had healed, as we also see after AFib ablations. Another thing that often happens after a VT ablation is very commonly a patient will have a change in their concomitant antiarrhythmic therapy. So somebody may be on amiodarone and combinations of other medications because they've been trying to quiet the VT. Now after the ablation, you remove some of those drugs, you reduce or remove the amiodarone, and something emerges that wasn't there before. And then the third possibility is that in changing the substrate, we have created another channel, or we've blocked off some channels, but not all the channels, and one that was there before becomes manifest.
But so just to follow up on that, so what do you do after a VT ablation in terms of drug therapy?
So what we typically do is, if they're on a high dose of amiodarone, that puts them at risk for toxicity. If they're on more than 300 milligrams a day, I typically reduce it down to 300 milligrams a day and wait for 2 months, anticipating that that's the healing phase, essentially, of the procedure. And then if they're doing well and haven't had VT after 2 months, then we recommend that the dose be continued to taper down as tolerated.
Now, sometimes during the procedure, it's difficult to ablate the VT, and there are technical reasons. We're not able to get the catheter to the right location. One of those examples are those patients with deep septal VTs. So the circuit is deep in the septum, and you can't ablate it from the left ventricle, and you can't ablate it from the right ventricle. And so then we try to apply, a variety of different approaches to deal with this. And I just want to touch on a couple of them and just have people's thoughts on these. One of them, and actually, Bill, you published something on this, is alcohol injection for VT ablation. Actually, in our lab, we did that in a few patients, and I would like Anu to maybe comment on this. From her perspective, and these are, again, patients where we can ablate technically with our catheter, and then we'll call our cath lab colleagues, and they'll come in. And if you could just comment on the technical aspects of what we make you do.
People may be thinking, what is the interventional doing in treating VT in the EP lab? I think ever since this group started, I think we've been working together in cases. I mean, they are real complex patients who have had multiple VT shocks and have had the ablation catheter and ablated, and then they figure out there is a focus somewhere that they cannot get their regular catheters, and that's the time we come in. Is mostly it's somewhere in the septum, So we try to get to any septal artery that comes either through the LAD, diagonal branches. There is a case we did of aberrant septal that actually came from the right coronary artery. So we have to keep, what we say is fishing and hunting for the septal till we know this is where the focus is, and then we go with the balloon and inject some alcohol, and most of these cases have been successful. That they have, the good thing is you see it then and there that the Vt is completely ablated as soon as we inject just a cc of alcohol.
Yeah, I have to say that, in most of these cases, we don't have that many cases, but the cases that we do, certainly acutely, they seem so successful. And first, I'd like, Bill, if you wouldn't mind commenting on, I think you probably have the largest world's experience on alcohol ablation. You published a paper in Circulation about a year ago. Could you just comment on what you see as long-term outcomes after alcohol ablation in these pretty complex patients?
Yeah, we've tended to use this as a bit of a last resort kind of therapy. So as you mentioned, they're very sick patients. And in our hands, about half the time we don't find a good target vessel has been a limitation. And that may be because there's just not a vessel that can be cannulated that seems to go to the area. Or we find a vessel, but there's a lot of collateral flow to regions that raise concern that, if the ethanol distributes into those collaterals, it may produce a larger area of damage than would be desired. When it works nicely, it can be much quicker than doing a radiofrequency catheter ablation procedure, and can be very dramatic. And we've had examples of it where it was clearly life-saving for those patients. And when it works like that, the long-term outcome has been quite good. When we can't find a target vessel, or we're struggling, and the patient has other VTs, then we've had cases where we're not able to get the patient out of the hospital. This, I don't think not because of the alcohol ablation, just again the bad substrate and the recurrent ventricular tachycardia that you just can't bring under control.
I can tell you my own feeling when we have a good case. I think, why don't we do this in every patient very early? And then we have the tough cases, and I think, oh yeah, now I remember why. So that's one approach. That's one of our weapons of mass destruction, so to speak, that can be quite effective. But sometimes we can't do that. Srini, do you want to comment on bipolar ablation? This is an approach that we've started using over the last year, and maybe you can just explain to the audience what it is and why it may work.
Yeah. Bipolar ablation is actually not new. It's been used in the 80s and such for pathways, WPW. When we do an ablation, it's basically what we call unipolar ablation, where we have a catheter tip electrode that we place on the tissue area of interest, and the return patch is an electrode, large patch, which we put, and it's a circuit, alternating current. And so the current goes to the catheter tip, it ablates tissue, and the return patch serves as a means for the return of current. Whereas when you have, what we started doing is, because we usually our area of interest is intramural, and it's hard to get to with standard unipolar ablation, which just does local area of damage. We started using bipolar ablation, where we replace the electrode patch with another catheter and place that across the tissue of interest. Now all the electrical current, the current density is focused right at the electrode tissue interface, and you get larger lesions. And Jacob's not here, but Jacob Cruz did a lot of preclinical work with that, and the lesion volume is massive, and these have helped us in situations that where we couldn't terminate VT. I don't think it's the complete answer to everything, but I think it is another tool that we can use.
So to that point, again, we're getting to this concept again of circuits that we can't quite reach. So there's this bipolar ablation approach you described, and it seems to be useful in some patients. But one approach that I think we're all very interested in is something that you published on recently, Bill, in your journal in Circulation, and this is the needle infusion catheter. So I mean, I hate when the discussion becomes too technical, but I do think this is important. And the idea here is the catheter has a needle, and it goes into the tissue, and then you deliver energy, so that you're delivering energy not just from the surface trying to make a lesion, but the surface and from the needle that's actually in the tissue. And Bill, you published on this first-in-man experience in 8 patients. You want to just comment on what you've seen? What do you think is the hope of it?
So this is a 27-gauge needle. It's very small. And when you infuse a little bit of contrast through the needle into the tissue, the contrast distributes in the tissue so you can tell where the needle is within the tissue and confirm that it's in the tissue. And then if you continue to irrigate and apply radiofrequency current, you can create an intramural lesion with it. And we applied it as a last resort therapy in 8 patients with one of my colleagues, John Sapp, at Dalhousie University in Canada. And 6 of the 8, we were able to bring their arrhythmias under control, and a couple of them were really quite dramatic, and all of these people had failed other standard ablation attempts, usually endocardially and epicardially. So it showed feasibility. And we had one tamponade that we didn't think we had done that with the catheter, but we can't be sure. So the experience was sufficiently positive that the FDA has given us permission for a limited feasibility study in the U.S., which we hope to start later this year. And in the spirit of full disclosure, I'm a co-holder of a patent on needle ablation, but I gave it to the Brigham for $1, so it's not my retirement plan.
Well, that may be your first very big mistake. We'll see. I think that, we were talking about this earlier. I mean, VT ablation, I feel it's come a long way, but at the same time, it's still not as effective as we want it to be. And the question remains, is it because we don't do a good enough job mapping, or we don't do a good enough job ablating? And the answer probably is a little bit of both. And I wonder if catheters like what you're describing are going to help us really understand what we can and cannot do. But what can we do and what can't we do right now? There's a publication, again in your journal, in Circulation, that's coming out, I think it's in press right now, called Help VT. This is a single center experience, a large number of patients, 227 patients, who underwent VT ablation. This is in Leipzig in Germany. It's a very busy electrophysiology center. And what they were trying to do is to compare outcomes in patients with post-MI VT versus patients with VT in the setting of dilated cardiomyopathy. And to me, this is very interesting because what we're seeing, certainly in the United States, is that as MIs are getting smaller and smaller, the use of statins, et cetera, infarcts are getting smaller and smaller, and we don't see as many post-MI VTs as we used to, just in our practice. We see more patients who have VT in the setting of dilated cardiomyopathy. And if you look at outcomes, and looking at this Help VT study, they showed while acute procedural success, that is the ability to terminate VT during the procedure, was similar in the ischemic and the non-ischemic patients, if you look at long-term outcome, it was dramatically different. The success rates in the post-MI patients were in the 60+% range, 60 to 70%. This is long-term outcome. Versus in the dilated cardiomyopathy, it was less than 50%. It was more around 40% of the patients had success. So, Bill, can you comment on what you see are the differences in terms of post-MI VT and dilated cardiomyopathy VT particularly?
Yeah, it's interesting. We're seeing more and more patients with dilated, so-called non-ischemic cardiomyopathies with VT as well, and I think it is a function of the defibrillators keeping these patients alive longer so that when they then experience their first episode of VT, they survive it and wind up then needing therapy for their arrhythmias. And these are almost always due to areas of scar that have developed in their myocardium. So although we're not used to thinking of non-ischemic cardiomyopathy as having a scar, in fact, they can get large areas of replacement fibrosis. And very often, when they have VT, you find that there's evidence of scar along the valve annulus, typically the mitral annulus. And unlike infarct scars, where there's almost always scar on the endocardial surface of the heart, which we can reach with a vascular approach to the endocardium, these scars can be intramural or epicardial. So those may not be so easy to reach and ablate from the endocardium, and often require an epicardial approach as well as an endocardial approach. And even then, you sometimes can't solve the problem because it seems like it's more of an intramural problem. So I think that the fundamental explanation between the worst outcomes with the non-ischemics probably is due to the differences in substrate and the location of where those scars are in the non-ischemic cardiomyopathy patients compared to the infarct patients.
What do you see as the future for these patients? Is it better ablation tools?
Yeah, I think so. I think that once we get tools that can reach the intramural areas, identify them and ablate them, then we should be able to sort it out, I hope. But again, I am concerned that when one of these patients starts having an arrhythmia, it's often a sign that other things are deteriorating as well. So getting back to the importance of a reassessment of their heart failure regimen and neurohormonal blockade.
Let's talk about the other end of the spectrum, which is Rv dysplasia. I look at Rv dysplasia as an area where Vt ablation is quite successful, unlike post-MI. Well, post-MI is not bad, but unlike dilated cardiomyopathy. Bill, would you comment on outcomes in Rv dysplasia, what the approaches that you think are most appropriate, and how do things look?
Yeah, there's been a lot of progress in arrhythmogenic right ventricular cardiomyopathy and dysplasia, and it's now, most of them are essentially a disease of the desmosome, where an abnormal desmosomal protein somehow translates into an accelerated course of fibrosis and fibrofatty replacement that interestingly starts in the epicardium, and then as the disease progresses, it moves endocardially. So when these people get VT, which they very commonly do, get monomorphic VT, the VT circuits are very often on the outside surface of the heart rather than on the endocardial surface. So one of the things that's now been recognized that has, I think, made a big improvement in the outcomes of catheter ablation for VT in that disease is the ability to go into the pericardial space percutaneously via a subxiphoid approach and to map and ablate epicardially. And when that's done, the outcomes are really very favorable for these people, particularly if they have well-preserved left ventricular function without left ventricular involvement.
So epicardial ablation certainly is very important in those patients. I want to get to a couple other things because I think we're close to out of time. But one area I do want to address is the patients with, actually there's two areas I want to address. One of them is the concept of looking at modulation of autonomic function. I mean, for many years, we've known the importance of the sympathetic nervous system and the pathogenesis of ventricular arrhythmias. This has been well described and it's been well appreciated, the role of beta blockade in these patients. Recently, there's interest in other ways to modulate the nervous system, autonomic nervous system. One is in a video-assisted thoracoscopic procedure doing resection of the stellate ganglion, which we know from animal models, if you stimulate, can induce ventricular arrhythmias. And the other is renal sympathetic denervation. Again, very little data, but there is preclinical data suggesting that renal denervation has profound effects on cardiac electrophysiology, and particularly atrial and ventricular electrophysiology. And there are a few case reports of performing renal denervation in patients with ventricular arrhythmias who couldn't otherwise be treated by drugs or cardiac ablation, and the claim that renal denervation has decreased subsequent ICD shocks. So I think this is a very interesting area. And actually, Mark, maybe have you comment on the trials that we're doing and what you think is, well, the hope.
Well, I think, the question you're asking is, will autonomic modulation be an appropriate adjunct to catheter ablation of VT? Because catheter ablation of VT, although successful, still has a 30 to 40% recurrence rate over the course of a couple of years. So for left cardiac sympathetic denervation, I think it's a different arrhythmia or different arrhythmogenesis than we're using for scar VT ablation. So left cardiac sympathetic denervation seems to be useful for repolarization abnormalities like long QT syndrome and things like that. We've tried it a few times in patients with long QT, it's worked, and we've tried it other times with patients with scar VT or let's say post-MI who've had monomorphic VT. It does not seem to be as successful. So you have to wonder what patient population we're targeting with that approach. But renal sympathetic denervation, which is, we're doing a trial now where we're actually randomizing patients after the catheter ablation to autonomic modulation via renal sympathetic denervation, catheter-based. hopefully will have some impact on the ventricular arrhythmia recurrence. And what impact, we don't know, because as you mentioned, sympathetic tone clearly plays a big role in the perpetuation and maintenance of these ventricular arrhythmias. So I think a little bit of time will tell. Obviously, the small case series that have come out in the preclinical work is very exciting, but I think a randomized trial is absolutely necessary prior to being implemented in a widespread basis.
So something potentially for the future. Last point I want to address, we've been talking about structural heart disease, infarcts, dilated cardiomyopathy, et cetera. There is one other type of cardiomyopathy that is related to PVCs, PVC cardiomyopathy. It's now, I think, well described and actually well appreciated that patients who have a high burden of PVCs, monomorphic PVCs, usually coming from the outflow tract, left ventricular or right ventricular outflow tract, who also have ventricular dysfunction, that this is a related issue. And if you eliminate those PVCs, either pharmacologically or by catheter ablation, the ventricular function typically improves and frequently normalizes. Now, having said that, there are a number of patients, Bill, who have a high burden of PVCs, who are asymptomatic, and whose LV function is normal. And at this point, we have no real data that says we should do anything with those patients. What should we do with them? Should we ablate them? Should we give them a beta blocker? Should we do nothing? How do we follow these patients?
No, so they all warrant a careful evaluation to exclude structural heart disease. Often MR imaging to exclude any scar, any abnormality, and that's often challenging if they've got a lot of ectopy. But then what we've been doing is we follow them. So there was a nice Japanese study that showed that of patients who had more than, I believe it was about 20,000 PVCs per 24 hours, that over the next several years, the risk of developing some degree of ventricular dysfunction was on the order of about 15%, if I'm remembering correctly. So it's certainly a significant number. And it used to be, you saw somebody like that, you ruled out structural heart disease, they were asymptomatic, we'd pat them on the back and say, don't worry about this, and not necessarily follow them. And now I feel they should all be followed with periodic assessments of ventricular function, because we don't know how to predict who is at risk.
How periodic? What's periodic?
So I start out with once a year. And then if we go for a couple of years and there's nothing, then we may, our thought is we might extend that further until some more data emerges.
Do you look at QRS duration, PVC QRS duration? There's some data to suggest in people with cardiomyopathy, the really wide PVCs, if you have 180 milliseconds or such, the PVCs are really wide. The cardiomyopathy is not going to reverse or partially reversible. So the question I have is anyone really thinking of prospectively looking at these wide PVCs and seeing if ablating them changes the course? I don't know the answer.
No, it's a good thought. If they've got any degree of ventricular dysfunction to start with, then I feel you need to get rid of the PVCs and see what their ventricular function is, and usually we usually recommend ablating it. But if they've got normal ventricular function, we've not been looking at the duration of the PVCs to try and help us decide, but we really need some more data. This will take a multi-center effort because these patients they're out there, but they're not that common.
So as usual, I'll monopolize the discussion. Are there any questions in the audience for anyone on the panel? Or comments?
So since this is controversies, let me ask a question. So we started off by saying that we have equipoise as to whether or not ICD shocks are harmful. They may be harmful, they may not be harmful. We then said we have clinical trials to show that doing Vt ablation or substrate modification decreases the frequency of ICD shocks without any evidence that it changes mortality, which then raises the question, are we doing this just to improve quality of life, or is there some other mechanism that compels us to, A, do alcohol septal ablation and induce infarcts in patients who have septal VT, B, implant temporary percutaneous devices and do 8 to 10 hour ablation procedures? Is it worth it? Why are we doing this?
Let me start off with that, because I just want to frame that question a little bit. I think that we have to separate VT ablation into the different patient types. So for example, the patients who have multiple ICD shocks, those are the ones that we would consider using alcohol ablation, using cardiac support, etc. I don't think any one of us advocates doing these relatively complex procedures for patients if the goal is as primary therapy. The second point I want to make is that it is certainly true that these primary prevention trials, or primary shock prevention trials, whatever you want to call them, have shown a decrease in ICD therapy, and it is certainly true that they've not shown a mortality benefit. But I just want to make it very clear, none of these trials were powered for that. So in fact, if you look at mortality like in SMASH VT, numerically there are actually 50% fewer deaths in the ablation group compared to the control group. But it was not statistically significant, and the most we could conclude is some measure of safety out of that. So those are the only 2 points I want to say. But having said that, I can see Mark and
So just one follow-up point, which is that's a beautiful hypothesis. The problem is that the history of EP is that there have been beautiful hypotheses slayed by the ugly facts of clinical trials.
Yep.
So, and I think that the history of EP really begins with the CASH trial, where we had a beautiful hypothesis. Let's get rid of the PVCs. We treated with the best drug that we had, enconide and flecainide, and we found out that at the end of the time we had to stop the trial because we were killing people. So I just bring it up as again, this is controversies to be controversial. I think it's important that we understand why we're doing things, not just because we can do them.
I'll comment. I mean, sometimes we take it as a knock, like VT ablation has never been shown to save lives, but that's okay. I mean, if you do a VT ablation for quality of life to reduce ICD shocks, I think that's as important. I mean, we do hip replacements because people have hip pain, doesn't necessarily save their lives. But the fact that it does reduce the ventricular arrhythmia burden and reduce ICD therapies is very important. The fact that it has not shown a mortality benefit is probably because we don't have the trial yet to show that. I don't know what the outcome would be, positive or negative, but none of the data so far, even the meta-analysis, is probably not powered to show that difference, whichever way it turns out.
Vivek, I'm sure you've looked at this. So how big of a trial would you need? Like how many patients to have an adequate power to detect a survival advantage?
Yeah. If you're looking at pure mortality benefit, it would be a big trial. It would be, I mean, Bill, you may want to comment, but I think we're talking about a 1,000-patient trial. That is a massive trial. If we look at another clinical endpoint trial, but not necessarily pure mortality, so say mortality plus VT storm plus cardiovascular hospitalization, then you get to numbers a little more manageable in the couple of hundred range, 300 to 400 range. These are not trivial trials, though. I mean, it's actually interesting. That's one of the reasons why one of the things that we're interested in is looking at other therapies that may be helpful, and one that we have interest in is renal denervation. So renal denervation, one of the nice things about renal denervation is that it's easy to do, it's simple, it's safe overall, okay? Yes, there's some complications that can occur, but the fact is, it's a less than 1% chance of major complications of renal denervation. You can imagine that a therapy like that, you could potentially implement very early in the disease state. For example, at the time of ICD implantation to decrease subsequent therapies. Again, this needs to be proven in a trial, and we're doing such a trial. But I think your point of making sure that the therapy is justifiable given the outcomes is well taken. You had one question?
Just a quick comment on the role of MR. You talked about the PVC. Should we maybe be doing more MR before we put ICDs in so that we use that for the VT ablation, or is it not that useful that it's worth that energy?
Yeah, it would be wonderful if the MR got to the point where you could finally characterize scars and actually see channels and identify arrhythmogenic scars and distinguish those that are not arrhythmogenic, and then use that to guide ablation. And someday I think it will be here, but it's not here yet. What MR is very good for, though, is detecting scars. So in someone who has an arrhythmia and you're worried, is this related to some underlying structural disease? We have a very low threshold for obtaining an MRI. I think it has taught us a lot about scar-related arrhythmias.
Okay, I think with that, we'll close. Thank you very much.